I am very happy to welcome everybody here to hear Dr. Heather Hirsch. I'm Dara Lee Lewis, cardiologist at the Lown Cardiovascular Group, and Allison Kelly Hedgepeth. Allison, wave.
Hi, everybody. Nice to see so many familiar faces today.
So we're the co-directors of the Women's Health and Wellness Program at the Lown Cardiovascular Group. And we've been hosting a series of webinars, which I think many of you have been able to attend, and you are all welcome to come to future webinars and invite friends who might be interested as well, because they're open to the public. And today we're really excited to have a very special speaker, Dr. Heather Hirsch. Dr. Hirsch is a nationally known expert on women's health. She's the clinical program director for the Midlife and Menopause Clinic at Brigham and Women's Health Hospital. She is an expert both in internal medicine and the intersection of internal medicine and gynecology as it relates to menopause and women's health in general. And she's going to talk to us today and for a part two on, where's your part two? It's in a couple of weeks on
July 1st.
July 1st, I'm sorry, on thriving in menopause in 2020. So without further ado, I would like to introduce Heather, and I will let you all know, please, you can send questions to the chat. If they're of a more personal nature and you want the questions to be anonymous, please direct them to either me or Allison Kelly Hedgepeth. We're going to mostly save the questions for the end, but if there's anything pressing, we'll sort of interrupt Dr. Hirsch as we go along. So Dr. Hirsch, welcome. Thank you so much.
Hi, everyone. Thank you so much for the opportunity to speak to you today about my favorite topic, which is menopause and midlife. And the reason I say that, just to give you a little bit of background before I start sharing my slides and going into my presentation, is when I was in training, I actually did a fellowship in women's health, and I came into my fellowship very interested in reproductive health, but it was there that I really saw people from across the country coming to Cleveland Clinic, which is where I did my fellowship, looking for answers about menopause, hormone therapy, and the things that affect women in midlife. And I realized it was the area where I believe there's the biggest gap in knowledge for women's health. So this is what I've dedicated my life and my career to. So a lot of what I do is a lot of myth busting, especially about treatment of menopause. But I want to kind of start this sort of two-part journey with you, going through just some of the basics and backgrounds about menopause. So I'm going to share my screen here, and let me see if I can get my, one second. Nope. I don't know if you can see this. Can anyone see my slides?
Not yet.
Not yet? Darn it. Okay, let me see. Hold on.
There's a little green button on the bottom that says share screen. Then you have to click on this what you want us to see.
I see something. I see trees and plants.
That's
You got it?
There we go.
Got it.
You're all set.
Okay, good. All right, everyone. Okay, so yes, for those of you listening, feel free to put some comments in the chat box. Of course, I usually do these presentations when we're all together, and so I can sort of see if people have questions. So do feel free to let me know. The purpose and the point to educate you is to kind of hit upon the things that you might not already know, and just to provide a good background in education. All right, so we got my slides up. So we're going to be talking about how to thrive in menopause and beyond. And a lot of that is understanding what happens to your body in menopause, and to me, how this plays a role in so mentioned, I am the clinical instructor of the Menopause and Midlife Clinic at the Brigham and Women's Hospital. And I do have some other resources for any of you who are tech savvy, because there is so much information that I could give on menopause and midlife and hormone therapy, and that you can kind of find out there. So I have started to implement some of my own resources, a lot of which I give to my patients. So I do have a podcast, Women's Health by Heather Hirsch, and Health by Heather Hirsch, which is also a YouTube channel where I post a lot of things there. So As mentioned, I now work at the Brigham and Women's. I actually started my internal medicine, I started my medical career in OBGYN. So I always wanted to take care of women, and I thought the only way I could do that was to deliver babies. And I found that actually my skills lied in counseling and spending a lot of time with my patients, something that I couldn't do as much of in OBGYN. So I actually changed career paths. I am now board certified in internal medicine and then did a fellowship on top of that, which is where I found my passion for midlife women's health. So this is all educational material and it's not direct medical advice, but feel free to see me for a consult if you would like to discuss anything further. I've been a consultant for pharmaceutical companies, mostly centered around getting their products FDA approved. And the goal of this presentation is to educate you so that you feel empowered and you feel excited about midlife and menopause. So I put this patient testimonial up here. This is a patient I had seen when I was in Ohio, and I was recruited to come to Boston, so that hence we're here now. And I love this quote, and she said I could use this, but I love how it says, "Lord knows if men only went through what women are expected to endure in such a graceful silence, there would undoubtedly be much more attention dedicated to research and treatments that would end this suffering." And I just sort of love that quote. So I love being able to be able to answer these questions. So just a bit about me. I'm a busy mother of two, and I love exercising. I love my job, and I've lived in New York, Ohio, and now in Massachusetts. All right, what you're all here for. Let's think about, I'm just going to take a little check the time. I have a tendency to talk a lot. So I want to be cognizant of the time. Let's start with just the basic definitions of menopause, because that's going to help us get into some of the questions that we have. The average age of menopause in the United States is 51 and a half. So I have some patients who are a little bit younger than that, say in their late 40s, and I have women who are older than that, say 55 or 56, but still on that bell curve. Really important is to consider early menopause, which is menopause between the ages of 40 and 45, and premature menopause, which is menopause before age 40. Most of what I'm going to be talking about when I'm making broad generalizations is based on sort of a natural menopause, but there is not one size that fits all. There's not one menopause. There's actually many different types, right? Because there's also surgical menopause. And surgical menopause is when the ovaries are removed. So I put in here, do you know what was removed? I've had many patients across my years who, for whatever reason, don't know if it was if one ovary is removed, both of ovaries are removed, if their cervix was removed. And so knowing what you may have had removed, if you had a partial hysterectomy, a slang term typically for just the uterus where you leave the ovaries in, or a full hysterectomy where they take out your uterus and your ovaries, it's important to know because surgical menopause is not just the removal of your uterus, it is actually the removal of both ovaries. That's going to make a patient have surgical menopause. So there's a lot of different types of menopauses, and these actually can play a role in how you experience it. It's one reason why you may not have the same symptoms as your sister or your neighbor or your friend. And then there's the evil stepsister, perimenopause. And I say this with a smile on my face because perimenopause for many women, not all, is sometimes much more difficult. And this is the time leading up to menopause. So by the textbook, menopause is 1 year or 12 months without any period. And by the textbook, your lab work will show a high follicle stimulating hormone level, and we're going to get into labs a little bit more, so don't worry yet about being too confused, and a low estrogen. So your estrogen makes your ovaries make all the estrogen in your body, and at menopause, as your ovaries shut down and go to sleep, you have therefore no more periods, your estrogen level is very low, and your follicle stimulating hormone, or what we call FSH for short, is very high. So I often say to my patients when they come to my office, and sometimes with their partners, that your husband or your partner, if you have a male partner, may be making more estrogen than you. In fact, probably is making more estrogen than you at menopause, and that's because men take a little bit of their testosterone, it gets converted to estrogen, and they make some estrogen that way. And then there's typically classic symptoms, but not always. So classic symptoms will be hot flashes, hot flushes, feeling warm, night awakenings, night sweats, as well as some other sort of less common talked about changes in mood, loss of hair, weight gain, fatigue, just feeling like you're aging really rapidly. These are all a lot of symptoms of menopause. Again, we're just in the intro, so we'll get into some of those. But note, very few women follow the textbook as it is written. So that's where sort of this clinical part comes in. I am sort of the menopause detective, if you will. And I'm thinking about your periods, your symptoms, and looking at your lab work, sometimes not just a snapshot, but over time. Now, the length of symptoms and major misconceptions about this is a big problem in my mind because the symptoms can last on average 5 to 7 years. So there's a social sort of notion that menopause is this 1 year, this period of transition, and then poof, you're back to normal. And that is, for most women, not very much the case. 10% of women never experience any symptoms, and that's great. I usually don't see them in my office. And 10% of women have symptoms that last forever. And I have seen plenty of these patients, and it is surely costing them so much of their quality of life, as well as length of their life. Once you're postmenopausal, once your ovaries have pretty much either gone to sleep at menopause or have been surgically removed, you're always postmenopausal. So this is something I always kind of go over with my patients. Menopause transition is going from perimenopause, where periods are sort of spacing or skipping, and you might start developing symptoms. And then the whole year after, if you look at your clock and you say, okay, it's been a whole year of no periods, you're postmenopausal, and you are always going to be postmenopausal after that. So a lot of people say, menopause for me was a long time ago, and really what they mean is that menopause transition. Your estrogen remains low for the rest of your life unless you take hormone therapy, which we'll talk about. And that low estrogen level is typically what causes a majority of the symptoms. And this can affect you, your life, your job, your friends, your social structure. There's about nothing that I haven't heard as embarrassing or as troublesome as it can be. I've heard a lot of things. So surgical menopause, I put this up here just because it's a nice little review of the lower GU tract if some of you have not really gotten a chance to look at it. So the big part here is, of course, your uterus, where you may, if you were ever pregnant, that's where baby sat and it got really big. These are your fallopian tubes, and your ovaries are actually not attached to the fallopian tubes. It's a little fun fact you can tell at your next party. Anyways, the egg pops out and comes out here into the fallopian tubes. So when your ovaries are removed, even if everything else is left in place, that is surgical menopause. The medical terms, hysterectomy means just the uterus was removed, and oophorectomy means the ovaries were removed. It's helpful to know if your cervix was removed, not so much for menopause, but in terms of your female health pap smears and things like that. If they do remove the cervix, which is right here, you don't necessarily, if your hysterectomy was for non-cancerous reasons like fibroids or heavy bleeding is the most common, then you don't need pap smears anymore. Okay, perimenopause is definitely very difficult, so I want to revisit this. It's the years leading up to menopause, and it can last anywhere from 1 to 10 years. So I have many patients tell me their symptoms started in their 30s, and that is correct. You can start having irregular periods, definitely hot flashes, definitely mood changes, and sleep changes. Those are sort of the most common things that can happen at the beginning of perimenopause, and I think that's one of the more harder transitions. So how to prepare for all of this and thinking about this, either just holistically or when you're going to talk to your doctor is really important. I know for many of patients who reach out to me, people that I see in the office, there's lots of barriers to talking to your doctor. Time, concern that this is not worth their time, it's embarrassing, or your doctor simply may dismiss it. In fact, that's actually a very pervasive thing that happens to women is they're dismissed. I've heard everything as well along those lines of, and it's just going to last a year, or there's nothing that you can do. And again, those are some of the main reasons why I have taken this to be my job, because those things are simply untrue. And we're doing a huge disservice to so many women at midlife. So how best to prepare, whether you're in perimenopause, whether you're in menopause or the menopause transition, or if you're postmenopausal and you're experiencing symptoms, anywhere along that spectrum, there's a lot of things that you can do. So I'm a huge fan of journaling your symptoms. It really helps when you come to your doctor to talk about your symptoms, to just sort of be able to look at it over the last couple of weeks to months to see if there's any patterns and to see how severe these are, and to really get a quick glance on how they're affecting your quality of life. So many of my patients find that it's affecting their job performance. Many people find it's affecting their relationships with their partner or their children, and being able to journal that is so helpful. And while you're journaling, people ask me what to journal. Include your symptoms, hot flashes, how much you're sleeping, how much you're exercising. Those are all important. We're going to come to that too. So I'll remind you about those. Try talking to your doctor, even if at first it's a little bit choppy. It's definitely a great place to start as your own physician. Of course, if I believe most of you are in the Boston area, so you're welcome to also talk with me, and I'll show you how to find other menopause experts. And talking with your family and friends. Now, this is actually an interesting point, is that oftentimes we will follow our mother's pattern. Now, it's not 100% that these are sort of genetic or inherited, but there are some similarities between perhaps maybe what your mother went through, or if you have older sisters or older cousins. So talking to them is really helpful, not just to know what they went through to see what you might expect, but to open the dialogue, to make it more normal that we talk about menopause, that we talk about our symptoms, and just again to increase awareness that this is a hugely important transition in women's lives. It shouldn't be something where we close the doors on conversation. And knowing your medical history is really important. Of course, when you go to see your doctor, knowing if you have a medical history, what medications you're on. For most of you watching this, I'm going to say it's safe to assume you're proactive about your health, and so you probably know your medical history pretty well, but I always put that point in there. So whenever I get interviewed, people always ask me if there's anything good about menopause. And I as I laugh, because we've already started to talk about some of the symptoms, but I actually think this is a fantastic time to refocus on yourself and refocus on your health. Women who are in midlife and menopause are so special because they're really actually at the peak functioning of their lives. They're usually at the peak of their careers. They're taking care of children, and they're taking care of, perhaps their parents and their house and their spouse, and just so many things. They're such valuable members of our job, our institutions, and our society, that it is a great time to really sort of reclaim putting yourself and putting your health first, because it's just a time where if you do that, it will definitely benefit you and those around you. So I have this sort of Heather Hirsch 4 pillars of health, which I think especially around menopause and midlife, before we get into some of the more, prescription types of treatments and debusting some of the myths about hormone therapy, just to go over these is really helpful. So the 4 big pillars of health that I want you to either track, journal, or think about as you're going into menopause is your sleep, your mental health, your exercise regimen, and your diet. So I'm going to talk a little bit about those. We're doing pretty good on time. The goal for sleeping is 7 to 8 hours of really good uninterrupted sleep. And especially if women are having hot flashes at night, or any type of nighttime disruption, this is a huge pathology or area where women are in a little bit of danger here, just because they're losing sleep. We as a society sort of, need 7 to 8 hours of sleep, and research has definitely showed your lifespan will increase by getting good quality sleep. Some of my just sleep hygiene tips I cannot go without saying. The biggest and the first is to remove TV from your bedroom. The TV is a distraction to your sleeping, and the reason being is you want your brain to think that your bed is for sleeping and sex only, or maybe just for sleeping, right? So you don't want to assume, or you don't want your brain to think your bed is where you hang out or you worry or you pay the bills, because it will start to do that. Not only do women have hot flashes and night awakenings at midlife, but they will start to have increased anxiety, whether that's hormone levels or, again, if it's environmental, because of all the things that are going on in women's lives at menopause. That worrying at night is really troublesome. So I always say, definitely don't keep the TV in your room. Don't do your bills or do your work in your bed. And if you can't fall asleep, if you're tossing and turning, get out of your bed, go to a room, a different room, sit in a chair and read a fiction book. That's probably the best thing to do. And then go back to bed when you're sleepy, so that you don't have bad associations with your bed. Of course, keep your room dark and cold. In fact, 65 degrees for women in menopause and midlife is the best, if your partner will let you do that. Remove things that wake you up, dogs, snorers, things like that. And have an AM worry time. And this is sort of a cognitive behavioral trick that you will learn to do if you don't already do. If you start to worry, there's absolutely nothing that's ever come from worrying at night that you've ever solved. And you tell yourself, I'm worrying, I'm going to do that in the morning, and instead I'm going to focus on falling asleep. This translates nicely next into thinking about our mental health. Again, because anxiety and other mood-based symptoms are so pervasive at menopause, that it's also a good time to get a hold of your mental health. So things that can definitely help are going to be meditating, journaling. Both of these are very nice introspective activities that you can do for free at home. There's so many meditation apps and things on your phone that you can use, and instituting them for just a couple of minutes a day make a huge difference, and research has been able to show that over and over again. Seeking support from a mental health person, if it's a psychologist or a sociologist or a counselor, if you're really struggling, can definitely be helpful. Reaching out and connecting with friends and family members. Obviously, now we're in a difficult time, but so many people are doing this, connecting over Zoom, and it's really having a positive influence. And exercise. And I always say that the main role of exercise is actually really to sort of elevate your mood as well as boosting your cardiovascular health, but not for bikini body. Don't exercise for that. Exercise for the mood benefits it gets you. When we exercise, we turn off a part of our brain that worries. We turn off that frontal cortex that's making all these decisions, and we sort of let it have a little bit of a break, and we light up some of the other areas of the brain, giving them some attention. So exercise to me is so important, especially in midlife, because we're going to talk about shifting metabolism, which almost all of my patients will say they've noticed weight gain in the front or around the belly. So exercise is good for those. It's good for your metabolism, but it's also good for just your soul to feel empowered during this time. So, do what you like. There's no specific exercise that you have to do. Do what you like. You do want to try and elevate your heart rate. So, I just got a new Fitbit, and it's motivating to try to get your heart rate up a little bit, but you do want to try and break a sweat when you're exercising, even if you do like walking, and that's walking is also great. But if you really want to change the physique, or if you want to change your metabolism, you'll want to add in some weight bearing activity and some activity where you elevate your heart rate, but do what you like too. You don't want to go from 0 to 100 either. Diet is definitely really helpful, especially in menopause and midlife. And I recorded a wonderful podcast that I think you'll get a link to, or that you'll get access to, if you want to learn much more about this from a fitness expert. Because obviously I'm the physician, I'm not the dietitian, and I'm not the fitness expert. But we talked so much about menopause, particularly at particularly at midlife, because there's so many unique challenges. So you can listen to that for a ton of information. But when it comes to thinking about diet, one of the biggest reasons it's hard to lose weight or is not just the shifting metabolism from the hormone changes, but also just the competing factors that women have in midlife. And I keep coming back to that, but it's such a time where women are they're really at the peak of being very, very busy and stretched. So, again, things that you already know. I'm sure your cardiologists have told you, and I just get to tell you again. We find that Mediterranean diet, which is a diet high in good fats, such as olive oil, fish, nuts, chia seeds, and those sort of lean proteins like turkeys, chickens is sort of what's in that Mediterranean diet. Avoid fast foods. And interestingly, in the last couple of months, a lot of us have had to eat primarily at home. And it's a good chance to wipe the slate clean to really see what it is that you're cooking with and what you're eating. Drink plenty of water. And again, in terms of what I say for menopause and diets, there's lots of different types of fad diets, especially popular right now is intermittent fasting, keto, things like that. From my standpoint, I don't have a particular diet that I endorse. In fact, I think the best diet is, especially if you want to lose weight, is just have a little bit of a calorie deficit and exercise, but otherwise not being restrictive and eating all the food groups. Most of the time, we under eat protein and we eat more carbs. So not saying keto diet is what I'm aiming for, but being a little cognizant of drinking plenty of water, increasing your protein, avoiding, fast foods. And again, I highly recommending listen to a dietitian on this exact topic too. Okay, we're a little bit past now where we are, a little bit past the introduction, and what we're going to kind of do, and after going through some definitions, is talk about lab work, and then we're going to also touch upon medical options for menopause symptoms, non-hormonal, and we're going to spend some time talking about hormone therapy. That will kind of take us up to the next sort of 20 minutes or so, where we'll do question and answer. And then in next week's session, I just wanted to give you guys an outline for those of you listening in. I'm going to be talking also about sexual function, sexual health, vaginal dryness, and other things that women ask me about in menopause, such as hair thinning, libido, some of those other areas. So just to kind of give you guys an overview. All right, so in terms of lab work, what lab work do you need? This is a question I get asked often. And when I see patients sometimes come to me after they've been to a couple of different doctors, they either have no lab work drawn at all, or they typically have too much lab work drawn. So while this is not necessary, if you're taking notes, you're welcome to sort of jot some of these down. But also the main message here is there's really a few basic labs that you need to determine or to when you're thinking about if your symptoms are menopause related. And recall that I said most women don't follow the textbook. So I really, really want to stress the point that when I am the menopause detective, I'm using so much of your history, your period history. I'm using so much of your symptom history, and I'm using labs as sort of a last data point. So labs are not the end all be all, but many of us do request that our doctors help us figuring out what these mean and what we should order. So again, when you're menopausal, your follicle stimulating hormone, or your FSH for short, is going to be high and your estrogen is going to be low. And likewise, if you're perimenopausal, your FSH is typically on the lower side. For those of you who are taking notes or want to know what I mean by that, an FSH level greater than about 35 or 40 on a consistent basis is consistent usually with menopause. And an estrogen level in the menopausal range is usually anywhere between 0 and 20. Now, to give you a reference range, when you were cycling, or if you still are, your estrogen will go anywhere from about 50 to 500, and during pregnancy, way up into the thousands. And so the estrogen level at menopause is really quite low. A lot of women, the estrogen level is 0, but some women do make a very small amount of what we call postmenopausal ranges of estradiol, and either that's from adipose tissue, fat tissue, or from the adrenal glands. The other things that I routinely will check too is thyroid, and this is because symptoms of menopause and symptoms of thyroid are so similar. In fact, a lot of women come to me initially saying they thought it was a thyroid issue. They're gaining weight, they're feeling hot, they're slow, they're sluggish, they're fatigued, only to find out their thyroid is completely normal, and it was most likely either perimenopause or menopause. And so I always check a thyroid level as well. Other things that I and that's really the basic workup. If a history is more concerning for other or more rare conditions or diseases, that's when I might order a couple other labs. But that's really the bare basics that you need is going to be that FSH, your estrogen level, your thyroid level, as well as your clinical history, what's been going on with you clinically for the last couple of months. Some patients will also check their A1C level if you have if you're developing prediabetes or diabetes. Sometimes that can cause hot flashes. Check a vitamin D and magnesium to make sure those important electrolytes and vitamins and prosteroid hormones are in the right range. For women who ask me about libido, and we're going to talk all about sexual health next week, I think that's so important. It's not something that should be avoided talking about or thinking about. I'll check their testosterone levels. And if a patient hasn't seen me, I'm completely new, I just check their basic metabolic panel and their liver tests just to make sure if we're going to start therapy that all those things are in check. And again, sometimes I do check for an ANA panel is for autoimmune conditions. Some of you may have those, and that's sort of a screening test. An MTHFR gene is also a screening or a reason why people can have some of the symptoms that are very similar to menopause. So remember, these levels will fluctuate, so they're not always steady. Estrogen goes anywhere from 50 to 500 when you're premenopausal. FSH is usually low if you're premenopausal. And so I do sometimes check more frequently. So more points on a graph might be helpful, especially if I have a perimenopausal patient. Sometimes not, just one screenshot in time doesn't help answer the whole picture. So don't get too hung up on your labs. If you have a doctor who can understand this fairly well, it's really thinking about you as the big picture. All right, so I just put in some examples here because I know a lot of patients really want to understand this because it is really helpful to sort of understand. So a common postmenopausal labs I might see is someone who said, I haven't had a period in 2 years, no bleeding whatsoever. This patient will probably have an FSH of 40 and an estrogen low somewhere around 20, or she might even have an FSH of 109 and an estrogen of 2. Both of those are postmenopausal. Doesn't mean that one patient's symptoms are worse or that her menopause is worse than the other. It doesn't mean anything. Both of these are pretty normal values that I might see for someone who is postmenopausal, no questions about it. Premenopausal patient, say someone's 35 and we just happen to check these. A very low FSH under 35, somewhere around 12, and an estradiol around 90. That's just where she was in her cycle. Now, perimenopause is where I said it can get sometimes a little bit dicey and you have to check a couple of times. For example, I might check one time and her FSH is 32, and then it's 24, and then it's 42, and her estrogen sort of bouncing around as well. And that's really common in perimenopause. FSH levels will fluctuate a little bit, as will estrogen levels. You're really also looking at the bigger picture of what my patient, what the woman is going through in terms of her cycle. So that's why I say track and journal, because it's so helpful for your doctors when they're putting this all together. Now, I wanted just to mention thyroid as well, just because thyroid is such a reason, such a confounding factor, or it's another etiology of why when you're coming to me with the symptoms that you're coming to, it could definitely be a thyroid. And this is just sort of for background knowledge. TSH is normal around 0.5 to 4.5. For women, it tends to be optimal around 2.5. And a subclinical thyroid condition is when you have a normal TSH, which is the one that goes to your brain. That message goes from your brain to your thyroid gland. But your T3 and T4, which are released from your thyroid gland, are abnormal. And we treat those based on symptoms. And I actually, I find these two conditions to be very intertwined. Also, if you are a patient and you have hypothyroidism, also known as Hashimoto's, and sometimes hyperthyroidism, which is Graves' disease, you might notice around menopause and perimenopause that all of a sudden you've been on a stable dose of Synthroid, and all of a sudden that dose is being needed to change, and it's related to those fluctuating hormone levels. And that can cause a lot of issues, especially when I'm talking to a group of some cardiologists here. Palpitations can also be normal or benign palpitations. Again, some of that racing heart, hot flashes, and so things we'd want to check would be your history and your lab work, including your thyroid. Vitamin D to me is very valuable. It's a pro-sterile hormone. It's not just a vitamin, it's a pro-sterile hormone. It has a lot of benefits. So the goal is to have your level around 30. They can also sometimes help women's mood and just overall levels of energy and functioning. So I always recommend 1,000 to 2,000 units daily, and you can get them anywhere over the counter. Now, testosterone, again, normal testosterone for women is somewhere really between like 5 and 45. Even if your testosterone's level is low, say it comes back at 10, that's still within the normal range. And the use for testosterone is really mostly for libido. So there's not good evidence to really show that testosterone replacement is great for fatigue or weight. There's a lot of trouble studying testosterone, and that's because it's not FDA approved in the United States, which makes the story about testosterone unfolding, and it's going to continue to unfold for a long, long time. But I'm mostly checking testosterone for libido if people are considering medications for libido. I want to mention just about finishing up lab work. I always teach my residents or my trainees, I almost never check a progesterone level. It's just unhelpful. It's low at menopause, and it's just really an unhelpful level in general. You don't really treat to progesterone levels. And I really don't check an LH level. And LH is a hormone that spikes right before ovulation, and it's otherwise, just because it has just a little spike in the cycle, is otherwise a very unuseful or unreliable test. So I don't check LH or progesterone for some of my clinicians who may be listening in and my patients who are interested. So to look for a doctor, the North American Menopause Society is a society that I'm a part of. It's the leading sort of group of guidance on menopause health in the United States. And if you are interested, they also have so much information here. You can look under the For Women part. You can find a menopause practitioner. Now, again, I always say this because I do this presentation not always just locally. So if you're local, you're welcome to see me. But in terms of, I think, Boston, it's me and Dr. Schifrin, who's at MGH, who's wonderful. But if you're elsewhere, you can always check this. But this website is jam-packed with a lot of good information. So we're getting to about 3:35, and I think I have about 15 minutes left. So we're going to talk about treatment options here. I hope I'm not going too fast, but I'm excited to see if you guys have any questions as we get into this. So as I mentioned, I spend a lot of time myth busting when it comes to medical treatments of menopause, right? There's a big message to society we send that you just have to struggle through this, and if you take some kind of treatment, you failed, or you haven't done it correctly, or you haven't done enough, whatever is kind of popular at the time. And that's certainly not at all true. When we think about menopause, it's essentially losing a very important hormone. And when we lose our thyroid hormone, we have no trouble replacing that with the synthroid, if any of you have a low thyroid. And to me, nothing is more natural than replacing estrogen or estradiol in extremely low doses if you're having very, consistent and life-altering symptoms of low estrogen. Let's start with non-medical treatments first, and then go into hormone therapy, which I'm sure many of you want to know about. So in terms of non-hormone therapy, what's shown to be beneficial is cognitive behavioral therapy and hypnosis. Now, I've actually never sent anyone for hypnosis. I can't actually say I recommend it too much, or I have ever recommended it. Cognitive behavioral therapy is working with a psychologist or psychiatrist to help essentially control your hot flashes and maybe your anxiety levels. I have some patients who do really great with this, and they really prefer to go a holistic route. There's no right or wrong way, and that's the take-home message. Not one menopause is the same, and there's no one way that we treat it. Cognitive behavioral therapy has worked for a patient of mine most recently who's learned to really slow her breathing, take deep breaths, do some Valsalva maneuvers, which helps to sort of lower her blood pressure and her heart rate, and that has significantly helped her, and she has done really great with that. things that are exercise, yoga. I never think exercise or yoga are bad ideas. So there's definitely probably no harm in doing these. What I mean by that is a clinical trial where they, do all the fancy statistics and get a lot of people to be enrolled in these studies hasn't shown clear benefit, but anecdotally, so many of my patients do better when they exercise, or if they're doing yoga. When you're doing yoga, you're stimulating your parasympathetic nerves, sort of your relaxing nerves oftentimes, and that can help also probably control some of those hot flashes, especially if you know what your triggers are. Another reason why journaling can be really helpful. There's been no proven benefit for over-the-counter supplements or herbals. Over-the-counter supplements, very popular is black cohosh, estrogen, progesterone creams. Many people will find benefit in the first couple months. That's usually a placebo effect. Placebo is very strong. There's placebo with everything, including Tylenol and Advil. But there's been no proven long-lasting benefit, but also those things are not harmful. So, I just put that there. As well as the same goes for acupuncture and chiropractic. No proven benefits. But again, if you have done well and those are working, then I see no harm in them also. When we're thinking about non-hormonal medications, there's actually only one FDA-approved non-hormonal medication for hot flashes, and this is called Brisdel. Brisdel is for my people listening who are not clinicians, is in the antidepressant class of medications. It doesn't mean at all that we think secretly think you're depressed and that's why we're treating you. Not at all. It's actually, there's actually a big, probably a big way estrogen and serotonin and investigate those interactions. It's also sometimes why when we give estrogen for hormone therapy, women find their mood gets significantly better and their anxiety goes down a lot. But we're not there yet, so we're coming up on those slides. But Brisdel is a non-hormonal daily oral medication in the antidepressant class. We found that for antidepressants, if you're already on them, it's actually the lower the dose, the better it will blunt hot flashes. The higher dose is going to affect things like mood. So you actually want to use these the best in really low doses. Brisdel is also for my clinicians, Paxil 7.5 milligrams or paroxetine 10 milligrams is usually what I end up prescribing because Brisdel is almost never a preferred medication. It's almost never covered. That's just a whole nother arena of women's health that unfortunately is just there, is that some of these medications are not covered. Other non-hormonal medications, for those of you who are interested, are off-label low doses of antidepressants, or SNRIs, which is another class of antidepressants. Clonidine, which is an old blood pressure medication. So I often find for my clinicians, clonidine sometimes at bedtime really does help if someone also has some high blood pressure. I kind of use it as last resort, but it's helped before. And medications for overactive bladder can help, although they have a lot of side effects. So, I do want to sort of share that that if we're thinking about non-hormonal or hormonal options for menopause, both have their own sets of risks and benefits, and there's not always one clear answer. So of course, I'm a little bit biased, and this is what I do for a living and read about and think about all the time. But I do think that there is a big, most, I think, primary care physicians or even gynecologists think about using antidepressants as first line, where I don't. I actually think about hormone therapy as first line. So now we're going to jump and talk about hormone therapy. And I have a good, I would say, couple of minutes left just to dedicate to hormone therapy. And this is why I wanted to recommend, if you're interested in learning a lot more, listen to my podcast or my, because I could talk forever on this. And it's so confusing. But the timing hypothesis is something that most menopause experts now agree on, which is that if you start hormone therapy within 10 years of menopause, there's particularly benefits for women, including decreased death from all cause. So women actually live longer and die less from all causes when women who have no known contraindications to estrogen, like an unprovoked blood clot or active breast cancer, take hormone therapy. therapy, they actually tend to outlive those women who don't. It actually is cardioprotective as well, and especially again within those first 10 years of menopause. Estrogen is actually a vasodilator, so it helps sort of open the blood vessels around the heart to increase blood flow and blood supply. There was, when a lot of confusion came out about hormone therapy, there was a lot of concern about cardiovascular incidences from taking estrogen, progesterone therapy, but we actually really see that in women who are further removed from menopause. So the timing hypothesis, again, is for women who are within 10 years of menopause. Women who are within 10 to 20 years of menopause have sort of a null effect on their heart, and the risks for cardiovascular incidents really increase if you're 20 years after menopause. So it's best if you do hormone therapy to start within 10 years of menopause. But I just want to say, for anyone who's out there saying, oh gosh, I'm 12 years out of menopause, it doesn't mean that it is absolutely off the table. It's just a long and different discussion on risks and benefits and routes and doses and things like that. So it's just a little different conversation. Not only does there a big benefit to starting hormone therapy within 10 years because it helps quality of life, it helps sleep, it helps bone health, it helps vaginal health, and improvement in quality of life. In fact, we also know that women who do take hormone therapy who are symptomatic live longer and die less from all causes. So I just want to also let you know that this is particularly for women who are symptomatic. So we don't use estrogen for primary prevention of heart disease, like maybe you are taking aspirin for primary prevention. So this is not primary prevention. That's a whole another conversation. But if you're symptomatic and you need hormone therapy, there is actually lots of benefits. Okay, I just said it doesn't, if you're after 10 years of menopause, you're not necessarily too late. It can still be used, again, as a long and different set of risks and benefits. That's where a very, very specialized physician is helpful. And sometimes we use different types and combinations or non-hormonal medications. And so that's where it gets very individualized. Now, what the heck does bioidentical hormone therapy mean? So many people ask me this, and so I wanted to break that down for you as we're kind of wrapping up hormone therapy. Bioidentical is actually simply a slang term that maybe Suzanne Summers came up with. It is just a slang term. It's not a medical term per se. What bioidentical really means is that the estrogen component in that medication is just estradiol. Now, there are plenty of FDA-approved estradiol products, and I only prescribe FDA-approved medications, and I highly recommend FDA-approved only medications for menopause. There's plenty of really great data on bioidentical, which is FDA approved, that I can send to your CVS or your Walgreens or wherever you get your medications, that is FDA approved. You want to avoid what we call compounded hormone therapy, which is something that you may be getting compounded. You're getting at a compounding pharmacy. So when I'm talking about the timing hypothesis and the safety of hormones within 10 years of menopause, I'm particularly talking about the safety of FDA-approved hormone therapy, be it a bioidentical option, which is estradiol, or a non-bioidentical, which is conjugated estrogen or something like Premarin, which many of you may have heard of Premarin. So, sounds like I'm saying this is the best thing, and there's there are, just like to any medication, there is always risks. The biggest risk with hormone therapy is the rare risk of a blood clot. It's about 1 in 1,000. It goes down to 1 in 2,000 if we use a transdermal, such as a patch, a spray, or a gel of FDA-approved estrogen. If you've had an unprovoked blood clot in your past, that prohibits its use for you, unfortunately. And then a lot of times I'm talking about the risk of breast cancer. And many people ask this, and it's complex. It's definitely lower if we use different types of or safer progestins. And the risk of breast cancer is higher if you're overweight, if you're obese, if you drink 5 to 7 glasses of wine a week, and if you smoke. And so a lot of us assume those risks already, but have this sort of ingrained idea that hormone therapy causes breast cancer. you know, that could be its own presentation in and of itself. But the risk overall is really extremely low. We can reduce that risk by using various different medications depending on your family history, your personal risk profile. But I really encourage you to also listen to my podcast on the safety of hormone therapy, in which I spend a good chunk of time talking about breast health. But the risk of breast cancer, or your breast health, should not prohibit you from thinking about or talking to your doctor about hormone therapy. Side effects can be bleeding, breast tenderness, and bloating, and oftentimes these actually go away, and that could be a sign to your doctor that we need to adjust those hormone therapy levels. Essentially, what we want to do is give you the lowest dose possible. So doses of postmenopausal estrogen are actually very, very low, much lower than when you were cycling a few years ago. But we want to give you the lowest dose, but the lowest dose that works, not the lowest dose that doesn't work. So are too high. That's where I come in, and that's why journaling is so important. And just rounding out this last part here, pellet injections are actually not very popular in Boston. I actually have been thinking and talking about it since I've been in Boston, and it's not very popular. So I'm going to pass this over pretty quickly, but pellet injections are definitely unrecommended. Again, they're compounded, and they can be really dangerous. Unregulated hormones, such as the compounded hormones, are so profitable, and that's why they're in so many places. And they're profiting off insecurities of laywomen and physicians to just prescribe FDA-approved hormone therapy when it's necessary, when it's affecting that person's quality of life. So unregulated hormones can cause all sorts of really concerning side effects, including unwanted facial hair, acne, scarring, permanent deepening of the voice, uterine cancer as well. Vaginal estrogens we're going to talk about in the next lecture. They're very safe because vaginal estrogens do not go systemically, and so we're going to talk about those a lot in the next one. In terms of what is best for you, it really depends on your individualized health, your medical background, your surgical background, your gynecologic background, and what symptoms you have. You can use hormone therapy for as long as needed. There's no longer a strict time limit on hormone therapy, but that discussion should also be individualized, and I typically recommend the lowest effective dose, and as women age, we can sometimes decrease that dose due to the changing of metabolism. All right, I wanted to leave about 10 minutes of questions. I know that's so much information. I'm really quite aware. It's a lot to take in. So I think what I'll do is stop sharing and get into some of these questions.
Thank you so much, Heather. That was wonderful, Dr. Hirsch.
Thanks.
There would be lots of applause right now if we weren't so physically distant from each other.
Yeah.
You know, the 4 pillars you spoke about are so important at the Lown group, and we talk about the same 4 pillars of exercise, nutrition, sleep, and stress management. So I'm glad you hit on that because that's so important with everything we do. Maybe I'll just start off with a question that incorporates in some of these that are in the chat about some of the vasomotor symptoms that we see in the peri and postmenopausal period. And I will say I've spoken with so many patients in the last few weeks that these symptoms are really affected by the baseline level of stress going on in the world. So these are not normal times. So maybe you can just say a few words about those symptoms and how we kind of deal with things.
Particularly for hot vasomotor symptoms, menopause, and stress?
Yeah.
Yeah.
And teasing them apart. Yes.
Great question. So a lot of women do tease out some of their stressors as they're either coming to see me or maybe after they see me. And certain stressors tend to be really common, including, of course, any change in temperature, spicy food, alcohol, and stress. In fact, my patient who was doing the cognitive behavioral therapy that I mentioned while I was talking found that she would get most of her hot flashes in the car. And she realized a lot of it had to do with road rage and driving. And then she sort of really realized a lot of it had to do when she had a spike in anxiety. And so stress is a really common trigger for hot flashes. It probably underlying has to do with the way our endothelial lining, so the little cells that line all of our vessels that send us all these messages, be it to our heart and to our brain, are essentially being irritated or inflamed, or sending signals. And with those change in pressure of those vessels, just like with blood pressure can spike with anxiety, that can also trigger hot flashes. So it is a very anxious time. And as a physician, there's a certain level of stress and anxiety right now we're all feeling, and there's just so many sources of stress and anxiety within the news. It's unavoidable. And so if any of you are experiencing more than usual, stress could be playing a huge role. And think about some of those calming techniques you can do at home. Your cardiologist may have also talked to you about that. Think about just slow, deep breaths. And sounds so cliche and silly, but it can really help kind of abate some of those hot flashes. Same thing in the middle of the night too, trying to not have, sometimes we can have more anxiety from just one hot flash. So whether you're experiencing them day or night, stress can play a big role.
That is wonderful and good advice for all of us. I think, how you mentioned the journaling, I think is really helpful for a lot of us to really understand our stress and be making connections with how, the external world is really affecting us internally. So thank you for that piece. When you're following patients and starting them on treatment, maybe you could just walk us through how you're assessing symptoms and maybe changing their regimen, because I think those are a lot of questions that we get. Maybe I hear, I'm still having palpitations, do I need to wear another monitor, or when can I expect things to get better?
Great question. So a lot of times when I'm seeing women, you as patients, I'm doing a lot of that detective work up front. And so the more you've tracked or journaled, and you might know that the more we may be able to see. But what I'm doing at baseline is, if we're using hormone therapy, which is typically what we'll do either in late perimenopause or menopause for if you're having symptoms, we can always check a baseline estrogen level. Some of my patients just sort of want to skip it. We think it's probably low, but it is sort of nice to see that level, let's say, comes back at 5. When my patients come back to see me and they say, Dr. Hirsch, I don't feel any better, I'm not feeling any better at all, and they're on a fairly normal dose. If we check their levels again, it might be helpful to see, well, wow, you must not be absorbing that because your level didn't move at all. If a patient comes back and they feel really well and they say my symptoms such as my hot flashes or my dryness or my palpitations feel under control, sometimes we'll check their estrogen level again, and I do like to see it somewhere around 50 for my women who are postmenopausal. But I always really preface this with what the patient tells me along with your labs, and I'm sure this goes for you cardiologists and internists as well. Make the whole picture. So even if you're, I'll have patients say, I feel great, and their estrogen level will come back at 30, and they'll say, well, shouldn't I do more? I've got more wiggle room. And I say, nope, if your symptoms are under control, that's just the dose that you needed. And then I'm playing detective based on any side effects you might have to make sure I'm not overdosing a patient. And we talked a little bit about those. So bleeding or terrible breast tenderness might be signs that the medications are too high.
Wonderful. So we're almost at 4 o'clock. There are some questions about low testosterone treatments and hair loss. So I don't know if those are things you want to tackle today, or if this is going to be in part 2.
I'll do my best to tackle it in 2 minutes. I actually have, for any of you who do watch YouTube, I did a whole video on testosterone, overdosing testosterone and why to use testosterone, just to point you there if I don't get all your questions answered. So testosterone's main role, as we've studied so far, is for low libido. And the goal, what NAMS recommends, is a very low dose of a physiologic level of testosterone. Typically, the way I do this is I use androgel, which we typically prescribe for men, ladies. You may have a partner who's on it, at 1/10 of the dose, a very, very tiny dose that you just put on your leg or on your arm. And the reason I check testosterone at first is just to make sure your testosterone isn't high or too high, because then it just means that there may be something else in your relationship that's causing the low libido, not just the low hormones, right? Maybe it's a marital problem or a sleep problem or something like that. And we want to make sure when we check your levels again after you you've been on like a female dose of something like androgels to make sure they never get too high. So for people who get big whopping doses of pellets injected in their tushies, which was very popular where I came from, actually in Ohio, you wouldn't think, and Texas and the West Coast, I see massive levels of testosterone up to 100 or 200, and where you can get permanent deepening of your voice, enlargement of your clitoris, lose your hair, and have terrible hair thinning. So hair thinning is really common in menopause from low estrogen. We don't want to worsen your hair thinning by giving you too much testosterone.
Wonderful. That was a great overview of a lot of information in a short period of time. So thank you for that. So we all look forward to part 2 of this, and I think we've addressed most of the questions. So thank you everybody for tuning in today. And Dr. Hirsch, thank you. We look forward for you returning in a couple of weeks.
Yes, I will. And please, if your viewers want me to talk about something let me know. We're going to sort of focus on some vaginal estrogen and sexual dysfunction and some of those other side effects for menopause.
Wonderful. And those surveys will come out to everybody. So if you do have things you want to hear about, make sure you type them in the survey. Thanks, everybody.
Thank you, everyone.
Thanks, Dr. Hirsch.